We are doing our very best to start right on time and give our speakers the full measure of the time. As you're getting seats, I will warn you that Nancy Hart's going to be standing right where I am, and if you want to see her slides, you may want to move to the other side of the room. You get a better view of what's up here, or you could be happy right where you are. End of life has been a topic for us this year, and I think that it is an important thing to consider for ourselves and for people we love. As Reverend Dr. Todd said, end of life can be at any point. Some of us find ourselves right there, and so it's good to be prepared and to know. One of the things that people who have read the Psalms find comfort in is these words from Psalm 139. If you're familiar with this psalm at all, you know that it starts with kind of the breadth of how God knows us and cares for us. But then it goes back to the beginning. You were there when I was formed in my mother's womb, it says. And then it keeps going on. It says, I can't go anywhere where you are not. If I go to the highest heights or the deepest depths, you are there, oh God. I have usually been caught up in that part, but then as it gets towards the end, it says, how weighty to me are your thoughts, O God, how vast is the sum of them. I try to count them, and they are more than the sand. I come to the end, and I am still with you. So I love that God is with us in the breadth of life, in the depth of life, the height of life, and the length of life from beginning to end. And that is our comfort. And I know that as we come together to think about these last things, it is a comfort to know that God is with us. Let us start with a word of prayer. Lord God, we give you thanks for your forever presence in our lives. For you are Alpha and Omega. You were there in the beginning, and you will be with us in the end. Lord, I ask your blessing over our speaker tonight, and I thank you for the gifts she offers every day, gifts of knowledge and compassion that she gives to her patients and to their families and to her staff. Lord, we thank you that she comes to us tonight to share her wisdom and her empathy with us. So I ask your blessing upon her as she brings us this presentation, and I ask your blessing upon these who are gathered in this place. May the words we hear tonight not be only for us, but may we share them where they can be employed as we go about our days. In Christ's name we pray. Amen. Amen. All right. Now, I'm going to introduce you. Sorry. Let's see. All right. So, Dr. Nancy Hart Wicker. I forget to add the doctor a lot because Nancy Hart Wicker is my friend. And so I'm delighted that she is a friend of mine and a friend of Westminster Presbyterian Churches, and indeed a friend throughout this community. One of the things I love about Nancy Hart is that she is mindful of the people who may not feel exactly like they belong, and she always moves towards them. And I really appreciate that. And I imagine that's super helpful in her work at the hospice house and in palliative care, as she moves towards people who need to know that they are in the circle of medical care, and they're in the circle of her care, and I think just by her presence in the circle of God's care. Nancy Hart Wicker has been at palliative care and hospice and palliative care of the Piedmont since 2016. And where she is now the medical Dr. Wicker, this is from her bio on their website. Dr. Wicker received her medical degree from the Medical University of South Carolina, so she's one of our own. She completed her residency at South Regional Healthcare and is certified by the American Board of Family Medicine. Dr. Wicker is also fellowship trained in hospice and palliative medicine and received her board certification in hospice and palliative medicine from the American Academy of Hospice and Palliative Medicine in 2021. We are delighted to have her with us tonight to share with us about palliative care and hospice care.
I'm going to hold this. It might be easier than me trying to stay in one place. Thank you guys for letting me come here. Thank you to Carolyn and Westminster Presbyterian for putting this series together, for talking about something that is very important but is sometimes avoided, often avoided, particularly in our American culture. So I was joking with some people earlier that the board has been wanting me to do this type of kind of community education for a while. This is the first time of me doing this exact presentation, so I said, well, at least I'll start with people who already love me. And so y'all can give me feedback, and if I need to alter it, let me know. But Walking Your Loved Ones Home, this was a title that was dreamed up months ago when Dr. Todd, Carolyn, and myself sat together and kind of dreamed up this series. And she reminded me earlier that this is from a quote, remind me, it is, we are all walking each other home, which I think is really lovely. And these are some really beautiful pictures of people walking together. Sometimes the walking home that we're talking about is not so picturesque. So I'm hoping to kind of help you guys know what to expect and access some help and tools down the road. So. The outline's pretty simple. I'm kind of going to go through the phases, the beginning stages of years, the middle stages of months, the end stages of weeks to days. What to expect, who can help you during those times, and what you should do to be helpful to your loved ones at that time. She already did a little introduction. Again, I know most of you guys, but I did put this in here in case someone didn't know. I always put my family up here first. This is a little bit of an old picture, but I'm Doctor Third, mom, wife, first and second, Doctor Third. So that's my most important job. And she kind of already outlined kind of my training path. I also have the unofficial badge of being trained by Dr. Bob Todd. So I like to brag about that. I followed Dr. Todd, and then he came after Dr. Jack Parham, and I always tell people it was like following Jesus and John the Baptist. You know, it's like really big shoes to fill. So why are we talking about this? Benjamin Franklin, in this world nothing can be certain except death and taxes. So death is the universal experience. It's interesting for a universal experience, however, we are to thinking about it, talking to each other about it, but that is why we're here today. I put these three pictures up here to remind you to just say a few things. One is death is natural, right? It is something that will happen to all of us. But if you have not experienced it yourself, which none of you guys have yet, or you've not experienced it with a loved one, there might be some things that you don't know about that before you've experienced it. It can be a bit of a roller coaster, some ups and downs, lots of emotions, sometimes sadness, sometimes anger. And I hope to give you some tools where it's not quite so much of a roller coaster. And that third picture is just there to remind you to say that death is unique to every person. There is no death that is alike. Dr. Todd and I have been with many different people, and everyone is different. People have diverse medical conditions, people have diverse cultures, and death is a very, very cultural experience. So everyone is going to be different through this process. So in the early stages, I'm going to walk through two different people. These are fictional characters, so this is a small town. Don't try to think like, who is she talking about? These are not real people, but they represent patients that we could very much see in our practice. So this is Maria. Maria is a 58-year-old school teacher who went for her annual checkup. She had lost a little weight, was feeling a little bit tired. Her doctor noticed a lump in her breast and recommended a mammogram. The mammogram led to biopsy that then led to PET scan. The PET scan showed breast cancer, stage 4 breast cancer with mets to the bone in the lung. She saw her oncologist who recommended surgery, chemotherapy, and radiation. The oncologist said, this is a treatable cancer. There are treatments that we can do for you that will extend your life. This is not a curable treatment. She gave her a life expectancy of about 2 years with treatment. Our next person we're going to talk about is Margaret. She's so cute. I love this picture. 76-year-old female with history of high blood pressure, diabetes, and hearing loss who presented dragged into the doctor by her daughter because she was starting to repeat herself. She was misplacing items. She was struggling to recall conversations. She had trouble managing her finances and recently had gotten lost going to the grocery store. Margaret was less concerned with her daughter, but her daughter was like, we really got to get you to see someone. So she goes into her primary care doctor. They referred to a neurologist, and after workup, she received the diagnosis of mild to moderate Alzheimer's dementia. They asked the doctor at that time, what is the life expectancy for Mom? He said, I don't know, maybe about less than 5 years, somewhere in that time frame. So we're going to follow both Maria and Margaret through their process. And these are very smooth cases because they access all the appropriate resources at the appropriate time. So early stages, what are the things to think about? Lean on your family, your friends, your community, and your church. All these are going to be really important all throughout this process. You're going to see this in every stage. Self-care. I feel like this, I almost didn't put it in there because self-care has such a weird name, like go get a massage or go get, I don't mean that. I mean access whatever self-care you can do as you're caregiving for someone who's going through a serious illness. You want to connect with community resources, and we'll talk about palliative care and hospice and how they can help you do that. There are support groups here in Greenwood and other places that will be helpful to you. There's a support group that meets monthly for caregivers of folks with dementia. There is an exercise class at the YMCA exclusively for people with Parkinson's. And there's day programs, lots of different resources, and it's going to be unique to wherever you live. So I'm speaking a lot from our experience here in Greenwood. However, some of you guys may be navigating a serious illness with someone who's far away. I will say the most common phone call that I get from one of my parents' friends is, my mom's in Texas. She's having X, Y, and Z problems. They've recommended either palliative care or hospice. How do I find that? How do I know the people I'm going to are good? That sort of thing, and we'll talk about that. If people ask to help you, say yes. I don't know why this is hard, but it's hard for me too, but if people say they want to help you, say yes. And sometimes it's just hard to think about, I don't know how you can help me. So one thing I heard someone say one time I thought was really helpful is when you have some downtime, write out the things that people can do to help you. So when someone says, hey, let me know how I can help you, you can say, these are the things that can help you. They may take you up on it, they may not, but at least you have some really concrete things they can do. Take an honest look at finances. I know earlier in the series y'all had an attorney that came and talked about some advanced care planning from a financial perspective. Sometimes the care you need as you approach end of life can be expensive, and you want to have a really good understanding of finances, and you also want to have it written down that if whenever this person cannot, maybe from a memory standpoint, access their own finances, that you have it written that someone else can do that for them. And then advanced directives. I'm not going to go into this a ton, but I do want to say a few things about it. So I actually have them in my bag, but my favorite kind of medical advanced directive is the South Carolina Healthcare Power of Attorney document. You do not have to have it notarized. It's pretty simple. And I do recommend you complete this. However, if you complete this and it sits in your attic somewhere, it's not really going to be helpful to you. So you want to complete it. I recommend giving a copy to your primary care physician so they can scan it into the medical records. You keep a copy for yourself, and then give a copy to whoever in that document you deem as your healthcare proxy. A couple of things about the South Carolina Healthcare Power of Attorney document that I would recommend is when you choose your healthcare proxy, they'll have usually a name for one person and then an alternative. I do not recommend dual healthcare power of attorney. In my opinion, that does not go usually very smoothly. Now, you can have backup, right, if your primary is not accessible for whatever reason. However, a lot of times when you have 2, 3, 4 people trying to make decisions all together, it's not real helpful. Now, of course, people can talk to each other and work together, but it's nice to have a singular person. Our organization, and I think maybe others out there, actually will help anyone in the community do an advance directive. This is a lot of legalese, and we have a social worker on staff for free to anyone in the community that will actually sit down with you and your loved one, complete the advance directive, scan it into the medical records, and give you each a copy. So very helpful. The other thing I would say is, in addition to doing that document, which is pretty black and white, I do recommend having a more nuanced sit-down conversation with your loved ones about your wishes. So you're not thinking about these things and talking about these things in crisis. You've already thought about them and talked about them ahead of time. So the smoothest things happen when it's like, you know, this is really sad, this is really difficult, but I know what my mom would want because we already sat down and talked about it. So have those conversations early as possible. You don't even have to have a diagnosis first. Sit down and have them ongoing because things change with your health care. And the last thing I want to talk about in those early stages is what is palliative care and how can they help? Palliative care is a relatively new specialty. Raise your hand if you've heard of it. Maybe probably everyone in this room. It is not the same as hospice, and I'll talk about the differences. But palliative care is a relatively new specialty, so we are not just educating the community like we're doing tonight, but we're still really educating the healthcare workers about what palliative care is and how it's beneficial. So it is specialized medical care for people with serious illness. That could be someone with cancer, like Maria, someone with dementia, like Margaret. It could be congestive heart failure, it could be COPD, it could be really any single serious illness or a combination of those things. Kidney disease, liver disease, anything like that. We focus on relief from symptom and stress of a serious illness. If you have ever gone through treatment of cancer yourself or been with someone alongside that, you know that it's incredibly stressful and comes with a lot of stress and symptoms. So that could be pain management, that could be treatment of depression, anxiety, insomnia, anything like that. The goal is to improve your quality of life. We have a holistic approach to care. So palliative care was one of the first specialties to do what's called the biopsychosocial model, which is the acknowledgement that we are more than our physical bodies, right? You can have physical pain, but we also have emotional pain, social, and spiritual pain as well. So we have a whole group of people working to address those symptoms. We are an added layer of support, and I just say that to say we're not replacing the oncologist or your cardiologist or your primary care doctor. We're here to come alongside you and all your healthcare team to support you. It is appropriate at any age or stage of serious illness. If you forget everything else, remember this. Most people access palliative care way later than they should. And they get on and they say, why didn't I know about this sooner? It would be appropriate at initial diagnosis, like both of these patients, to get on board with palliative care. So you have time to develop a relationship. You have time to, again, have those conversations, to get advance directives done, and to help with symptom management that comes along with having a serious illness. And it can be provided along with any curative treatment. So you do not have to choose palliative care or chemotherapy or palliative care or dialysis. You can get palliative care along with all of those things. Physical therapy, again, dialysis, chemo, radiation, all of those things. Where can you get palliative care? You can get palliative care, at least in our community, just about anywhere. This is going to be one of those community-specific things. If you are helping a parent who's in another state, you might have to figure out what's available there. Here in Greenwood, we have palliative care in the hospital. It's self-regional, where if you're in crisis, a team can see you there and help you. We can see you in a facility, whether that be in a skilled nursing facility or assisted living. I have Wesley Commons picture there, but we go into many others. We can come to your home if you're having trouble getting out of your home and see you there. And then we do have a clinic next to our hospice house where we can see patients there. I think most large healthcare systems are going to have at least clinic palliative care and hospital palliative care. Home palliative care, maybe everywhere does not have that. So I think that's probably the most important one to have personally. Does insurance pay? The short answer is yes, most of the time. Insurance Medicare and Medicaid covers palliative care. Most private insurances do as well. However, if the cost is a barrier, find yourself a nonprofit hospice and palliative care agency. We see patients regardless of payer status, and there are places like ours, most larger areas. What can I expect from palliative care? Again, relief of symptoms. Focus on your experience of the treatments. Your oncologist is going to be really fighting hard to treat your cancer. We're going to be fighting hard to make make sure your experience of that treatment is as good as possible. We're trying to help you carry on with your daily life as much as possible. We look at your patient and the family and the caregiver as a unit. We know that an unhealthy caregiver is an unhealthy patient, so we really try to help both of them together. We can assist with advanced directives, and then we really try to provide good communication. Dr. Todd talked last time about how healthcare has become so fragmented. If you've been through any illness recently, it's like you have your primary care doctor, you might have your cardiologist, and then you go in the hospital and see your hospitalist, and then you come home and you maybe have 6 people, and maybe sometimes it feels like none of them talk to each other. You're like, did you even read the medical record? And we really try to kind of bring all those voices to the table, get and help the patient and their family have a really good understanding of what is going on with their health care. How do you access palliative care? You may have to ask for it. Again, we're doing a lot of work in educating the community, but also educating healthcare workers about what palliative care is. But there's still a lot of misunderstanding about it. Ask your doctors, tell them, hey, I heard about palliative care and I think it might help my loved one. And do your research about which organization you choose. Again, I'm speaking as if you may be somewhere outside of Greenwood. Use word of mouth, who in the community has a good reputation. Ask your doctor, hey, who do your patients go to when they need palliative care? When you see an organization, ask about the training of the folks you're going to be seeing. Because it's a newer specialty, I think people put the word palliative care on a lot of things and they maybe don't have any specialized training. You certainly want someone taking care of you that has some specialized training and experience with palliative care. So ask those questions. And I'll talk a little bit more about that on the hospice end as well. All right, so the middle stages. So we went through the years, and we're going to go to the middle stages. Maria. So Maria goes through her surgery. She goes through her chemo, her radiation for 2 years. She actually does relatively well. She's referred to palliative care and develops a very strong relationship with her palliative care nurse practitioner, Christy, up there on the top left. I did not get permission to use these people's photos. These are all team members of mine. Christy helps her complete an advanced directive, appointing her husband as her healthcare proxy. Christy helps her manage some of the nausea and nerve pain related to her chemotherapy, and she receives social, emotional, and spiritual support from her palliative care chaplain, Josh, and her social worker, Christy. So you see this beautiful team of people that are helping support Maria and her husband through this process. Unfortunately, about 2 years in, she gets a new scan that shows her cancer has progressed and is no longer responding to chemotherapy. Her oncologist said there are no more options for treatment directed at cancer, and the oncologist and her palliative care nurse practitioner recommend hospice services. That can feel very scary when you hear that first word, hospice, but I hope to teach you tonight that hospice is not to be feared when you need it. All right, Margaret, our little lady here who has dementia. So she enrolls in palliative care for several years alongside her neurologist and primary care physician. Her palliative care nurse practitioner, Keela, up there on the top left, helps them complete advanced directives on their first visit. This is very important with dementia because just because you have some early memory problems does not mean you cannot complete some advanced directives, but it's really important to do that as early as possible where they can still participate in that process. Keela also helps her daughter with medications to manage her mom's nightly sundowning and agitation. The social worker with palliative care helps her daughter access a local support group of caregivers of loved ones with dementia, as well as a senior adult day program where her daughter can go run errands. So again, beautiful team of people helping Margaret and her daughter navigate her dementia. Over the next few years, she continues to have weakness and increasing memory loss. She gets to a point where she needs help with all of her activities of daily living, walking, toileting, dressing, bathing. She starts having recurrent urinary tract infections and was recently hospitalized with a pretty severe one. She says very few words and is sleeping 18 to 20 hours a day. You are having trouble getting her to her doctor's appointments because she's so weak it's hard to get her into a car and take her there. You remember hearing about hospice and bringing it up to Keela at your next appointment, and she agrees that it is time to enroll in hospice. So when you're in that middle stages, right, when someone has said, I think hospice is appropriate, a lot of the advice in this is going to be similar, that self-care, leaning on your support system, whether that's your church, your friends, your community, saying yes when people offer it. Think about hospice. And again, I'm going to talk to you guys a lot about what hospice looks like and how they can help you through this time. Possibly this is time where you might shift away from the treatment and cure to focus on what is the greatest quality of life possible. What is important to your loved one now? And then it's hard to think about these things, but I promise it's better earlier rather than in crisis. You might start thinking about some funeral arrangement, again, if the patient can participate in that. It's easier done earlier in the process. What is hospice? Hospice is not that scary word that you hear and think of. It's specialized medical care for people with serious illness who are terminally ill, so typically less than 6-month prognosis. It's focused on relieving symptoms and stress of serious illness, and once you're no longer seeking cure, but desire symptom management and highest quality of life. I made this really complex diagram to show that all of hospice is palliative care, but not all palliative care is hospice, so they are not equivalent. But basically, it's the same approach to care at different stages of your illness. Hospice, though, the hospice benefit does come with a lot of added support that I'll describe next. So what can you expect? You can expect with hospice a whole team of patients. It's probably the most extensive home care that you can get. It's a whole team of people. So you'll be assigned an RN or a nurse case manager who will come maybe once a week if everything is stable, up to every day in crisis or close to the end. You have a CNA that can help with bathing and other household tasks, and again, some people opt out of that to make up 0. Our CNAs can come up to 5 times a week. I will tell you, the CNAs are the folks that our patients love the most because they see them the most. Sometimes they see them every day for a period of time, and sometimes people graduate from hospice. It's not super common, but it does happen, and the CNA is always the one that they miss the most. We have a chaplain on staff to help with any spiritual concerns of the patient or their family. We have a social worker to help with either emotional support or accessing resources. And actually, when the hospice Medicare benefit was designed, it's required that 10% of your hours are actually volunteer hours. So we have, at our organization, like up to 200 volunteers that do different things in our organization, but there are some that have volunteered to actually sit with patients. Very important, very helpful. We can do it up to 4 hours a week. So again, we'll have a volunteer in there that will sit with your loved one so you can go. I had someone last week who said, "My volunteer Mike came and sat so I could go get my hair done." And I was like, well, that was probably really helpful. Because some of our patients cannot be left alone. So very, very helpful. And then you'll be assigned a physician. Your community physicians can remain involved, but you'll be assigned a hospice physician as well. There's a 24-hour call line. I think this is probably one of the most helpful things to patients as well, because things always happen on nights, weekends, holidays. Mine's nodding your head. And sometimes you're like, I don't want to go to the ER, but I really need to ask someone this question, right? So it can be 2 in the morning on a Saturday, and you will call this line, and you will get a nurse on call. And they have a doctor to back them up if they have questions. They might just be able to give them a simple advice over the phone, or they might say, hey, I'm going to be there in 30 minutes, and I'm getting in my car right now. Either way, that is huge for people, right? Help them avoid the ER, help them stay at home, but get exactly what they need. So we provide medical equipment, so if someone needs a hospital bed, or a bedside commode, or a shower chair, anything like that, oxygen, we will have that all delivered to the patient's home. And then we do medication management. All the medicines involved in this patient's hospice care is all covered under the hospice benefit. And actually our organization, I think a lot of them actually do mail order, so you don't even have to go to the pharmacy to get them. They'll actually mail them, deliver them to your house. I'm always surprised that they just FedEx people medications, but it does happen. And it's very convenient for our patients and their families. So where do you receive hospice care? So hospice can be done pretty much anywhere you would call home. So in your actual house with your family, or in a facility like Wesley Commons, or assisted living like here locally in Emerald Gardens, Ashley Place, all those. Hospice can go in there and serve you. We have the hospice house. Not every hospice, again, if you're thinking about outside of this area, not every hospice has a hospice house. Not every community has one. We're very blessed to have a hospice house in Greenwood. I think that the people who had the vision to raise the money to do that was very good. But hospice house is for someone who is at home and then they have a crisis and they need to come in. They have that. They also have respite care. So part of the hospice benefit, everybody has this, the right to this, is you can have 5 days of respite. So if you're caregiving and you need to go to the beach to be with your grandkids, your loved one can come to the hospice house, receive the care they need, and then go back home. So it's a really good resource to be able to have. And when you're choosing your hospice, again, if you're outside of this area, that is something you should have. What is your inpatient option? Every hospice has has to have a contract for an inpatient option, but it could be a hospital, it could be a nursing home, or it could be a hospice house. So ask those questions again if you're trying to find an organization to use. Does insurance pay for hospice? Short answer is most of the time Medicare and Medicaid covers it fully. Many commercial insurances do as well. Some of the kind of catastrophic insurances do not. But again, as a nonprofit, and there are other nonprofits, we will serve you regardless of your ability to pay. So do not let cost be a barrier, and most of the time it is covered by insurance. How do you get it? Ask your medical team. You can self-refer. So you can call our office and any office for a hospice, ask to be evaluated for services, and they will come out to your house and do so. They'll probably gather some medical records, get a release of information, but they can come to your house. You do not have to get a referral from somebody else. You can do that yourself. Do your research. So again, really common call, like from my parents' friends, you know, mom's in Texas, she's in the hospital, they want us to go home on hospice, they presented us a list of 12 organizations, what do I do? And I always say, I get online and I look up www.cms.gov and I put in their zip code. And they will have the organizations ranked, and you can look at that. And it's all based on quality measures that are pretty much things that you would want for the people taking care of you. You would want somebody who responded to your pain. One of the questions they ask is, would you recommend this hospice to somebody else? So that's a pretty important one. How many visits did my loved one get in the last days of their life? Those are all quality measures, and it's a 5-star rating. So you can look and see which are the highest star ratings that serve my area. I think that's a really helpful, again, when you're in an unfamiliar area. If you're in a familiar area, use word of mouth and reputation. Again, ask your physician who you usually use and recommend. Ask about the training of the people that will be working with you. And I do say, and I'm sure some of this is my own bias, but I recommend using a nonprofit hospice. There's actually, the New York Times put out an article that said hospice is a profitable business, but nonprofits mostly do a better job. So actually nationally, they are ranked higher on those quality measures, and they provide more services. So again, if all things are equal, I do recommend finding a nonprofit in your area because, again, they tend to have the higher quality measures and provide more services to your patients. So, all right, so we've gone through the early stages, we've gone through the middle stages, and now we're in those late stages. I'm calling late stages the weeks to days. So what do we want? What can we expect? What do you do that might be helpful to your loved one during this time? So we're getting back to Maria. So Maria was enrolled in hospice for 4 months. She develops a strong relationship with Haven, her hospice nurse, and her physician, Dr. Wicker. Her CNA, Patricia, comes 3 times a week to help her with her baths, and her social worker and chaplain continue regular visits to support her and her family. Maria makes a quick change and starts only eating bites or sips here and there, sleeping most of the time. She's unable to get out of bed, and our hospice nurse feels that her time may be as short as less than 2 weeks. Again, just pointing out this whole team of people that surround your loved one and you during this time. All right, well, Margaret. So she's enrolled in hospice as well. She loves Lauren, her hospice nurse. They always love the nurses and CNAs best. I only take a little bit of offense to it, but. Lauren helps her daughter understand kind of what to expect every step along the way. Her hospice physician helps them understand prognosis and, again, to know what to expect and prescribe medications when she needs it for the occasional urinary tract infection or nighttime agitation that she may experience. She has a CNA, Miranda, that comes to help with her baths. Her social worker, Shakita, helps her daughter access the caregiver voucher to help pay for a Wednesday night caregiver so she can go to Bible study. She comes and stays at the hospice house for a week of respite so the daughter can go on vacation with her college friends. Susan is a retired nurse. She's actually our volunteer coordinator. This one's fake. I didn't know I want to put our volunteers up here, but she comes and stays every Sunday morning so she can go to church. So again, wonderful team of people surrounding her during this time. She remains on hospice for 5 months. She slowly increases the amount of time she's sleeping, starts eating only sips and bites, has even some coughing whenever she tries to eat or drink anything. Her hospice physician and nurse pay a visit, and they discuss that her prognosis is likely just a few weeks. So both of these patients are in those late stages. So what can you expect in that time? So withdrawal. Withdrawal is very common in these late stages. Kind of in the weeks before someone dies, they're staying in bed most of the time or all the time, spending more time asleep than awake. This is a very normal part of the process, and is typically not due to medication. there when they're awake, but if they're sleeping, it's usually best to let them rest. So if you know they're more awake in the mornings or in the afternoons, you may time your visits for when they're most awake. Say who you are and say what you're doing before you do them. Our CNAs really model this very nicely. I'm going to turn you on your side. I'm going to remove your blanket. We're going to do your bath right now. Even if they're sleeping and they don't seem to be responsive, tell them what you're doing as you're doing it. If you're worried medication might be contributing, you can discuss this with your care team. And one of the things that Dr. taught me is that they tell us is the hearing is the last thing to go. So even if a patient is resting, they will find comfort in your familiar voice. So speak to them in a normal, calming tone. Say to them the things that you want to say to them, even if they do not respond. However, if they're resting, a lot of times it's best to let them rest and not feel the need to wake them up, because that can sometimes result in agitation. Another thing we see in this stage are changes in eating. So patients may stop wanting food or drink. This is very, very normal. This is difficult to see and accept because in the South here, food is love, right? And so we think that if we're not feeding someone, we're not loving them. And in this stage, that is really not true. It does not mean the person feels hungry or is being starved. That's what people really worry about. I don't want my loved one to starve to death. That is not what is happening. The brain's normal drive for food and drink just goes down in this stage, and they're not feeling hungry or thirsty. You know, I always say, I skip a meal and my stomach is growling. They're not feeling that same discomfort. So what can you do to help? Do not force food and drink. I think this is really one of the hardest things for a lot of people. If the person asks for food and drink, you can check with the care team. If they say it's safe, offer it. They may take a few bites and be done. That's okay. A lot of our patients at this stage, if they do eat anything, they like cold, sweet, and soft foods. So things like applesauce, pudding, ice cream. I'm like, please feed me ice cream if I'm sick, you know? Liquids may be better than solids, and sometimes you don't have to thicken the liquids. You might do small ice chips, or frozen juice can help with any thirst that they may have. And you want to look for those nonverbal signs that they may be wanting something to eat. And at the very near death, they're likely not eating or drinking anything, and we will do some mouth care. Again, if you guys have experienced hospice, they have these sponges and they use them to clean the mouth out to keep it moist. That is likely at that stage all they need to have to prevent discomfort from any thirst or anything like that, keeping their mouth nice and moist and not dry. So really, this is a really hard one, but they are not suffering from hunger or thirst at this stage. They may experience changes in toileting, so loss of bladder and bowel control can happen at end of life for most people. You obviously want to make sure that they remain clean, dry, and comfortable. Their urine may change color and be dark and cloudy or strong odor, and constipation can be fairly common, especially if your loved one is requiring pain medication. So what can you do? You want to check them often, right? Because they may not be able to tell you that they have urinated. Give them as much privacy and dignity as possible. The hospice will provide briefs and pads, and that can be helpful. The hospice aides, as far as changing, they have given me a lot of tips over the years. They don't teach us how to turn a patient in med school. Nobody taught me that, so I had to learn that in hospice because sometimes it's all hand on deck, and I'm like, I'll do whatever you want, but like you're gonna have to teach me how to do it in a way that's not gonna break our back. So ask your hospice aide for tips on how to change someone safely and comfortably. Sometimes we'll do a catheter that will help with decreasing the amount of times we have to turn a patient if they're having discomfort with that. Definitely keep track of bowel movements. Hospice nurses are kind of obsessed with asking about bowel movements, but it's because this can contribute to discomfort for patients, and we certainly don't want that. Changes in breathing. This is something that we often see at this final stage of life. So breathing patterns can change. Very, very near end of life, you may actually start to hear people have trouble swallowing. They have weakness in the swallowing muscles, and you might hear a little bit of rattling in their breathing. You kind of want to get a suction catheter in there, and suction it out is really not recommended. I know it's really hard to listen to, but does not necessarily, these breathing changes do not necessarily mean a person is suffering. One thing people see sometimes is they'll have apnea or pauses in their breathing, where they'll kind of pause their breathing and then pick back up again. Not uncomfortable for the patient, very, very common. Can be alarming if you don't know it's coming, right? Because you're like listening for breathing and it stops. If they have a change in their breathing, certainly point that out to the team. We can help walk you through what you're seeing and whether or not that means they're uncomfortable or not. Sometimes we provide oxygen that can provide comfort sometimes. And due to mouth breathing and stuff like that, you just want to make sure you keep their lips and mouth nice and moist. And as far as that rattle goes, not everybody has it, but it's much harder for us as family members than it likely is for the patient. There are some medications that we can give at that time, and the most important thing, and again, the nurse will instruct you on this at the time, is actually to keep patients kind of turned on their side. So a lot of this stuff you may forget, but the biggest thing to know is if you see a change that you're concerned about, bring it up to your hospice nurse. They are experts at noticing these things and walking you through what's happening. Changes in temperature are also really common. So the part of your brain that regulates temperature kind of starts to shut down as well. So if someone can have a fever a lot of times at the end of life, and you might do cool washcloths, you might remove blankets. Sometimes we give Tylenol if it seems really uncomfortable. You may have to change clothes and sheets more often because they might be sweating. Sometimes we have a fan, or you might open the windows or the doors depending on where they are. So sometimes people are cool, so you might use a warm blanket. We usually don't recommend like an electric blanket, but we might do warm blankets, or sometimes even gentle massage. So probably check with your nurse first, because for some people that might be more uncomfortable. And a lot of times patients at this stage, their hands and their feet get really cool, but they're not necessarily feeling cool. It's more of just a sign of circulation. So it's not really going to be alarmed up, but it is something that you might notice. So we're going to go back to our friend Maria. So Maria starts having some trouble swallowing her medications. Her nurse Haven and Dr. Wicker changed her medications from pills to liquid to make it easier for her to swallow. She does well with that for a few days until one night, late at night, her husband calls. She's having increasing pain, and he has given pain medication like instructed, and it has not helped. The on-call nurse instructs him to give a higher dose and then decides to pay them a visit. During the visit, she remains in pain despite a couple of doses of the liquid medication, and after discussion with the doctor and the patient's husband, they decide that she meets criteria and would be helpful for her to go to the hospice house, where she is transported as soon as they possibly can. She actually starts getting injectable pain medication, so she cannot swallow the liquid medication, and that helps her be a lot more comfortable. At that point in time, she's really not even drinking much at all, and she's sleeping almost all the time. She passes about 8 days very peacefully after her transfer to hospice house with her husband at the bedside. And then Margaret, she slowly makes changes, slowly over the next week starts to sleep all the time. She goes from getting a CNA 3 times a week to every day, and her nurse starts coming every day as well. She has minimal pain and requires only occasional doses of Ativan for restlessness. She stops eating and drinking, and her nurse goes one day and notes that her knees and her feet feel cool. Her breathing is shallow, and she tells her that she thinks the time is close. She reminds her, don't forget, if something happens, this is the on-call line. Please call us any time of day. She passes one night peacefully around 11:15 at night. The daughter calls the on-call line, and the nurse comes out to see her. She makes the pronouncement, she calls the funeral home, and she waits with the daughter until they arrive. Our bereavement team reaches out the next day to offer condolences and make sure that the grief team is following up with regular intervals. Her husband volunteer comes to the service and sits with the family as they have become quite close. So what to remember about hospice: we are here to help you. We are not to be feared. Most people, I think I said this about palliative care, sign up for hospice and palliative care too late and wish that they had accessed the support and services much sooner. Again, these are really the ideal scenarios, right? This person accessed all the right resources at all the right times. When the first time I meet someone, they're in the hospital in crisis and they're actively dying, that's not the best process, right? Because families haven't been given this luxury of time to really process what's going on and get all the support they need to help. When I was thinking about what I was going to talk about, I put something out on one of our hospice physician boards. I said, I'm talking to the community about walking our loved ones home. What suggestions do you have? And one of them said this, and I thought this was a kind of helpful thing, not just for community members, but probably also healthcare workers as well. So if you're thinking about like how much longer do I have or my loved one has, if you're seeing changes or declines year to year, you probably have a life expectancy of years. If you're seeing changes month to month, you or your loved one likely has a life expectancy expectancy of months. If you're seeing changes week to week, you likely have a life expectancy of weeks. And if you're seeing changes day to day or hour to hour, you likely have a life expectancy of hours to days. I thought that was kind of a helpful thing. I don't even know who to quote because it was another physician on one of these boards. But what to remember afterwards: lean on the people around you. If things get really difficult, go to your primary care physician. They can help with any treatment you may need for depression or anxiety. There's no shame in that. Part of the hospice benefit is you have to be providing grief services for up to a year afterwards, so use those resources. We will reach out to you, like I said in that one scenario, usually within 48 hours, and then we will reach out regularly after that. And then if someone is kind of a higher risk for complicated grief, we might do much sooner. And then they can access other resources like support groups for you if you need them. Remember to do the things that your mom would tell you to do: eat, drink. I always tell family members, like, have you eaten anything today? Have you drank anything other than the coffee in your hand? Go outside, move your body, do the thing that you need to do to be healthy during your time of grief. So that's all I have to say right now, but I definitely would love to answer any questions that you'll have. Yes, sir. Wow, that was great.
I have instruction and a question.
Okay.
So the instruction is, please repeat the questions into the microphone for recording.
I remember that one last time.
Thank you. But the true question is, how are you not sad all the time? I mean, just hearing the case studies of Maria, was Margaret was the other one? Mm-hmm. I'm tearing up over here, and I'm sure others were too. How do you do it?
The question was, how am I not sad all the time? That's a good question, and I mean, the people who know me really well, Dr. Todd and Carolyn, know that I wouldn't say I'm sad all the time, but I am a little burnt out sometimes. But I think it's very rewarding. You know, these stories are going to happen whether I'm there or not, but I think it's the reward of being able to help people through their challenging time is, I think, what fills the cup when sometimes it's also being emptied at the same time. But I mean, we cry too. Our team, you know, we have times where we debrief as a team for really challenging cases, and we are sad sometimes too, yeah. I go outside in nature. I try to turn my phone off. I don't know. I think you could say that about a lot of things. How do you teach middle schoolers, you know? How do you stay at home with your kids? How do you do hospice care? I think, you know, choose your heart. But, it's really I mean, truly, it's very rewarding to me and very lovely to be able to help people. I don't know if you have anything to say about that, Dr. Todd, but.
Well, you know, I've thought about that a lot over the years. Do I need to? Oh, no.
It won't stretch to you, so you're going to have to come to it.
You know, when I get asked that question, you know, I look back at the beginning of medical school and early part of our career, and the satisfaction that we get is making a diagnosis, prescribing the right medicine, watching somebody get better, and that gives us satisfaction. In hospice, you know that the patients are terminal by definition, or else they wouldn't be able to be in hospice. But providing them with comfort, supporting the family, you know, euthanasia means good death, but we don't use that word. But
We don't do that either.
Yeah, no, yeah, but there is a good death in the sense that, you know, somebody is coming to the end of their journey or going home, and you know, we're able to provide, we as a team provide support, pain relief, symptom management, and that becomes the satisfaction. You know, emotional, spiritual, you know, physical comfort, and you know, the other thing I think that we have had with Hospice Care of the Piedmont is the support of an incredible team and the volunteers. And I can't speak, Nancy's been a volunteer for, ever since I've been here, and Larry. And, having the support of the volunteers, people that you can unload with, even in these circumstances, people have a sense of humor. I remember we had one patient who was within days, but he was still alert. He was, a CNA was coming into his room in order to give him a bath. And he was laying there still, and she went over to see how he was doing, and he wasn't breathing, and then he said, "Boo!" I bet you thought I was dead. And she screamed, and I just died laughing when I heard the story. And his wife, just fussed at him for doing that to the CNA. But that kind of humor always, just makes us feel like it's not always sad. I've always often thought about whether Christians and non-Christians die differently, and to have a Christian who is ready to go home, brings us a great deal of comfort. So it's, I think it's been probably one of the most rewarding things that I have ever done.
Yes, thank you. What he said. Yes.
How many beds do you have at Hospice House?
He asked how many beds we have at our hospice house. We are staffed for 9 patients. We have 16 rooms, but some of those are used as storage, and one of them is my office. But right now we are staffed for 9 beds.
Are you often full?
We always keep a bed for a home patient in crisis. So we will not fill our last bed with someone in the hospital who's getting what they need. We will fill our last bed for someone out in McCormick who is in crisis. Does that make sense? So I would say full no, doing a little bit of bed management, trying to make sure everyone gets what they need sometimes, yes. What'd you say?
I said that seems so few.
It's a little bit of a, a balancing act sometimes of, again, I think we try to, especially a home care patient in crisis, we will expand for that. And we did expand during the hurricane. There was no power anywhere, and our patients on oxygen had no way, we had extra tanks for 2 or 3 days. No one was prepared for 10 or 11 days. So we did expand our capacity during that time. So, yes.
Do you have patients that need a visit even though they don't know the people?
He has to
Or do your volunteers provide that?
Do we have patients who need visitors because they don't have visitors? Absolutely, yes. And we do have volunteers who do that. We always need more volunteers who will do just that. I will tell you, I think our biggest need for volunteers is actually people willing to go into patients' homes. It can feel a little bit nerve-wracking and scary. You really don't know what you might be walking into, but of course we would prepare you. But absolutely, we have people who don't have anyone to visit them in our skilled nursing facilities or even in their homes. So always need people to do that. Yes.
Lucia.
My husband died too many years ago now from a degenerative neurological disorder, and he was diagnosed as he was put on. I'm going to say this right, on hospice, and then they came in and said we can't serve him anymore because he's living more than 6 months. And so, is that still? So they had to take him out hospice and put him, we had to scrounge around and find some way to cover what we've been doing until I don't know, it was very upsetting and frustrating at the time.
Her question is, and it's related to her husband, is, once you are on hospice for 6 months, do you come off hospice? Is that your question, basically? To be on hospice, a physician has two physicians have to deem a person to have an estimated prognosis of less than 6 months. Now, that doesn't mean at 6 months that someone gets kicked off hospice. It does mean at 6 months or all along the way, we have to be documenting, like, even though it's been 6 months, this person continues to lose weight, continues to have increased weakness, continues to have X, Y, and Z thing happening that makes us think that it's still appropriate. So there are people who graduate from hospice because they think they're pregnant. At some point it's like, oh, maybe their prognosis is not 6 months, right? That's an art, not a science estimating that. And it is incredibly difficult when that does happen. I do think that, we try to not do that suddenly, which is what maybe it sounds like happened to you. This is something that we do with preparation over time. And before we do that, before we have to remove those resources, if and when that happens, we try to access as many other community resources as possible. And we would transition back to palliative care, there's actually, we just started a program, it's called Principal Care Management, which is kind of palliative care plus some added touch points throughout the month. So I hope that it doesn't feel sudden to folks. But we have people on hospice for a year or more, as long as we can kind of continue that
This
justification.
doctor diagnosed you as terminal,
Yeah,
and, you know,
I'm sorry that
same
happens.
here at that point.
Yeah. Yeah. Yes.
With regard to the palliative care team, you referred several times to we, and you mentioned a PA, maybe.
Nurse practitioner.
Nurse practitioner. What kind of training, other than you being the doctor, are the palliative care people on your team?
That's a great question. So our palliative, she asked, what is the training of our palliative care team members? So we have actually expanded our palliative care team a lot. When Dr. Todd was there, they had a full interdisciplinary team, and at some point that was no longer, but we now have that back up and running. So we have 3 nurse practitioners. 2 of the 3 are certified, are palliative care certified through hospice and palliative care. The third one is working on her certification right now. We always are working toward it. We get a new person. There is a palliative care certification for every specialty, and I want all of our team members to have that. Our palliative care, Christy, that I put up there, she's been doing palliative care for 20 plus years, and she was the first to get, and I'm going to mess up what it's called, but the palliative care certification for nurse practitioner. She was one of the first in the state to do that certification and pass the exam. So we have a palliative care RN who's working towards her certification, and then social worker and our chaplain do not have specific palliative care or hospice training, but our clinicians, hospice as well, we're wanting them to either certified or working towards that. That's pretty important to our organization.
So you don't have volunteers in the palliative care team?
You know, we have not historically utilized volunteers in palliative care. However, we have had people who graduated from hospice and they love their volunteers so much that they continue to visit, and that's not a problem. The other thing that's kind of exciting about palliative care, and this is maybe beyond what y'all care about, but I'm excited about it, is we are trying to figure out how to do more integrative therapy and medicine in palliative care. So aside from medications for pain, are there other modalities like massage therapy, acupuncture? We just got trained in Reiki therapy, and there's actually a volunteer who comes to this church sometime, Becca Lewis, who's helping train some of our staff, and we'll be doing that for our patients that want it. And we actually just found a volunteer who's going to do some massage therapy at our palliative care clinic for our patients undergoing therapy. I'm very excited about that because massage therapy is usually for people who can afford it, right? So that they're volunteering their time. So like while they're at their palliative care clinic, they can do like a 20-minute session. So there's some volunteers, but they have historically been used more on the hospice side.
I just wondered if they're, getting really down low on the talent pool. rung, is there anybody there that actually sits and holds your hand
In palliative care.
and listens?
You're talking about palliative care.
Just listens.
She asked if there's anyone with palliative care who just sits and holds your hands and listens. I guess volunteer-wise, probably not, but I hope that is what our team, there's somebody on our team that does that for people. And I think a lot of times we walk in the hospital, right, and our social worker and nurse practitioner, we've been consulted to do X, Y, Z, but yet this person has received a brand new diagnosis of cancer, and they really just need to sit with that for a little bit, right, to sit in that discomfort. And I think that whatever it says about us as people, we're pretty able to do that. It's hard to be, it's overwhelming, isn't it? Yes.
Can I just say, I have been around care of the Piedmont since it was the original beginning. And I was on the crowd that raised the money for the hospice care. There is no way that I can't say enough good things. I mean, it's just impossible for me to express my thanks and my observation of what a wonderful job Hospice now Care of the Piedmont is doing.
Do I need to repeat that? Probably not. Thank you so much. And truly, like, a lot of this was built and dreamed up well before me. Just to tell the story that 40-something-ish years ago, Jack Curran, who has since passed, who I consider kind of one of our founders as well, had an experience with a loved one who was kind of in a rural area and she was dying, and he could not find the help to come to her to get what she needed. And he was like, I think we can do better. And hospice was kind of in its infancy. He started reading and learning. He went to England and went to the first hospice, the hospice house there, learned about it, and really kind of brought it to Greenwood. And for a place the size of Greenwood to have been such an early adopter of hospice care as a concept is pretty amazing. And to have a facility like ours in Greenwood, where I did my fellowship in Columbia, there was not a hospice facility like
We
ours.
were the second hospice house in the state of South Carolina.
Yeah.
Wow.
And you know, insurance rules the world. And hospice houses do not make money, and the community of Greenwood has been what has kept that place open for our community members. So it's a really lovely thing, and the thrift store, I guess, too. I'm glad we have it. It's really helpful to
Store's
people.
done a lot.
Yes, our
For a
hospice
lot of
goes
people
for us,
that
too.
can't pay.
Yeah.
I think, go ahead, please.
There was, not a question, but a comment. Like Ms. Nancy was saying, unfortunately, I've had family and friends, I've been in hospice like 4 times that I've been there. As late as my aunt 3 weeks ago was at hospice, and nothing but good things to say. I mean, very helpful, professional, I mean, the whole 9 yards. I mean, if you had a set of people that you wanted to be at your inner life, it would be at the hospital.
Thank you so much. I would say it's a place you don't want to be, but if you need it, it's a good place. So thank you for saying that.
It's a good final word. Nancy Hart, I want to thank you, and I think that my feeling in hearing your presentation was Hospice House and you and the staff there and the volunteers really fill out what I was trying to share about Psalm 139. We know God's presence through those hands and hearts and knowledge that we get at Hospice House. Whether we're a caregiver, whether we're a pastor helping a family walk their loved one home, your knowledge gives a real grounding for that, and the care of your staff does that for us. for those of us who know that Jesus is ready to greet us on the other side, that somebody is walking us home. And so I appreciate that, and I hope that for many people. Next month, we'll be talking about grief. And we'll have a chaplain here to talk about that. But there's some very interesting things that we're learning about the neuro experience of grief. And so I'm going to present part of that talk on what that is. And one of those things is knowing where our loved ones are. Our brains right now know where our loved ones are. You have a map for your children, for your siblings, for your parents. You know where they are. And as people of faith, when a loved one goes home to be with Jesus, it is helpful to us to have in our neuro net to know we know that person moves on the map for us because we have a sense of that eternal life. So we are comforted by that in ways that people who don't have that don't have. So we'll talk a little bit about that next time, along with a chaplain who works in the grief work with folks. So I hope you'll join us again on March 20th at 5:30, and let's give Nancy Hart another. Please feel free to stay for a little while, visit with each other, get to know one another, share your hospice stories, and we'll see you next month.